Good afternoon, everyone. My name is Dominic Akatiba, and I'm with Ghana Medical Help. Welcome to this week's presentation on our maternity service agenda. This is a program we started this year to improve upon our knowledge and skills in maternal and newborn care. Over the last months, we've done a couple of topics, and our last presentation was on obstructed labor. Today, we are looking at a very important and common topic in the practice of medicine and in obstetrics and gynecology, urinary tract infection in pregnancy. Today, we are being led by Dr. Hawa, who is a consultant gynecologist at the Tamale Teaching Hospital, my own boss, and Dr. Ibrahim Khaliq, who is with us at the Upper West Regional Hospital. Dr. Hawa, please take it from me, and then you guys can start the presentation. Thank you so much.
Thank you. Thank you so much for the introduction, and welcome to everybody on this call. We are gathered here today to have some more knowledge and remind ourselves of the common things that happen to our pregnant women and how we can alleviate their difficulties. Urinary tract infection in and outside pregnancy is a common condition that affects women. And when in pregnancy, we will get to know what happens and why it is more common amongst pregnant women and how we can pick it up to avoid some of the complications that Dr. Khaliq is going to talk to us about. So I welcome Dr. Ibrahim Abdul again. He is with the WA Regional Hospital. He's a medical officer and he's with the obstetrics and gynecology unit. He's going to share with us about urinary tract infection in pregnancy. Over to you, Doc.
Thank you very much. So I am Ibrahim Abdul Ali Attaruwa, and I'm a medical officer with the Upper West Regional Hospital with the obstetrics and gynecology department. I'm here to present on urinary tract infection in pregnancy with my supervisor being Dr. Hawa Melaki and our moderator being Dr. Dominic Akatiba. So with the outline, we have the definition, etiology, risk factors, classification, mode of spread, clinical presentation, investigations, treatment, and complications. So let's start with the definition. Well, urinary tract infection generally is an infection within the urinary system, including the tubular interstitium. That is the interstitium of the kidney.
I forgot. Let me switch from here.
Yeah, that is the interstitium of the kidney, comprises the extravascular intertubular spaces of the renal parenchyma with their attendant cellular elements and extracellular substances. Urinary tract infection is simply a bacteriological diagnosis that's based on culture of a single bacterial species of appropriate colony count from appropriately collected urine. For the suprapubic aspirate, any amount of count or growth of the microorganisms can be used with a diagnosis. For catheterized sample, counts of greater than 10,000 organisms per milliliter of urine, and with the midstream specimen of urine, a colony count of greater than 100,000 organisms per milliliter of urine. Now we come to the etiology. Well, urinary tract infection in pregnancy can arise from a variety of causes. Primarily, it is attributed to the anatomical and physiological changes, particularly the increase in progesterone levels. Now, this leads to relaxation of the smooth muscle tissues throughout the urinary tract, including the ureters and the bladder. Now, the relaxation actually reduces urethral tone and alters bladder dynamics. This contributes to urinary stasis and making it easier for bacteria to ascend from the urethra to the bladder and potentially to the kidneys. Additionally, the enlarged uterus, usually with pregnancy, uterus enlargence, as we all know. This can mechanically obstruct the ureters and obstruct urinary flow. This predisposes pregnant women to urinary tract infection. Hormonal changes also affect the vaginal flora. That potentially increases the colonization of uropathogens. Moreover, physiological changes in the immune system during pregnancy, such as a decrease in cell-mediated immunity, may impair the body's ability to combat bacterial infections effectively. Now, together, all these factors create an environment that is conducive to the development of urinary tract infection in pregnancy, highlighting the importance of proactive measures to prevent and manage these infections to safeguard maternal and fetal health. Now, with the organisms that causes urinary tract infection, it should be noted that the organism that causes urinary tract infection in pregnancy are the same uropathogens that commonly cause urinary tract infection in non-pregnant patients. E. coli is the most common organism that is isolated. In fact, an 18-year retrospective analysis found E. coli to be the most common causative organism that is present in our 60% to 82.5% cases of pyelonephritis in pregnant patients. But it's not only E. coli that actually causes urinary tract infection. Other bacteria that may be seen include Klebsiella pneumoniae. That is about 11% of cases of urinary tract infections. Proteus, about 5% of cases of urinary tract infections. Staphylococcus, Streptococcus, and Enterococcus species. Gardnerella vaginalis and ureaplasma are uncommon pathogens, but they may also be isolated, especially in women with underlying kidney disease. It should also be known that group B Streptococcus is commonly isolated from urine culture in the third trimester. And even in the third trimester, it is said that group B Streptococcus is the most common organism, even more common than E. coli in the third trimester of pregnancy. Now, there are some changes that actually occur in the urinary system during pregnancies. The first is kidney enlargement. Now, this also causes stasis and thus providing a pabulum for the colonization and proliferation and growth of microorganisms. As we already stated, now the enlarging uterus, the gravid uterus actually compresses on the ureters and the bladder. Now, this actually also causes the accumulation and stasis of urine, thus providing a conducive environment for the bacteria to thrive. Incomplete emptying of bladder also influences the collection and the stasis of urine, thus providing a conducive environment for the bacteria to thrive. Now, with pregnancy, usually the urine is not that acidic. So it also creates an environment for the microorganisms or the uropathogens to thrive. Now, we also find that in pregnancy, actually, the urine actually contains more sugars, protein, and hormones. As we already stated, the hormonal changes actually influencing or making pregnant women susceptible for urinary tract infection. The sugars and protein also creates a conducive environment for the bacteria to thrive, or influences its proliferation and also its growth. Now, with the risk factors that are, the first is gender, that is women being females in the first place actually is a risk factor for urinary tract infection. And the reason is because women or females generally have a shorter urethra. Females usually have a shorter urethra. Hence, the time taken for the bacteria to ascend is usually shorter as compared to men. Males usually have a longer urethra, so it takes a longer time for the bacteria to ascend. However, with women, they have a shorter urethra. Hence, as we will see later, there could actually be infection of the urethra, and this could ascend to the bladder and ascend potentially to the kidneys. So women having a shorter urethra actually predisposes them to urinary tract infection. The second is the extremes of age. Now, we found out that individuals with or women that are less than 20 years old and also women that are greater than 35 years old usually have a decreased capacity and reduced contractility of the bladder. They usually have a decreased capacity and reduced contractility of the bladder. Now with this encourages stasis and accumulation of the urine in the urinary system. And thus, this creates a pabulum for the proliferation and growth of uropathogens, causing urinary tract infection. It starts from the lower urinary tract, that's the urethra, causing urethritis, ascending potentially to the bladder, and because of their short urethra, and potentially to the kidneys. Now, we also have comorbidities such as sickle cell disease. Now, in sickle cell disease, we already know that most organs are affected, including the kidneys. Also, with sickle cell disease, the white blood cell count is usually low, and thus impeding fighting against infections. That's also making them susceptible to infection, especially urinary tract infection. Now, with diabetes mellitus, there is increased concentration of sugars in the blood. Now, this also influences increased concentration of sugars in the urine. An increased concentration of sugars in the urine provides a perfect breeding ground for the bacteria to thrive. With iatrogenic, well, the tight sling for the treatment of stress incontinence actually leads to stasis of the urine, thus providing a pabulum for the proliferation and growth of uropathogens. There's also when there's also infrequent voiding, that's usually sometimes seen in pregnant women. There is accumulation of the urine and also for a longer period of time, because due to the infrequent voiding, and thus this creates a perfect breeding ground for the bacteria to proliferate and grow, and also causing urinary tract infection. Now, with sexual activity, about 75% occur within 24 hours after coitus. Now, it should be noted that the bacteria or the uropathogens that cause urinary tract infection is usually found around the region near the anus. Now, with that, any form of sexual activity, be it oral sex, penile-vaginal penetration, or any form of sexual activity, could actually lead to the pushing of bacteria closer to and up the urethra. So it could be pushed or transferred to the genital tract and subsequently to the urinary tract or the urinary system. Thus, it could start from the lower urinary tract, causing urethritis, ascending to the bladder and potentially to the kidney. So any form of sexual activity could actually influence the pushing or the transfer of uropathogens from the area near the anus to the genital tract and subsequently to the urinary system and causing urinary tract infection. Now, generally, renal tract abnormalities, for example, the scarred kidneys, neuropathic bladder, and whatever, usually also cause are also risk factors for urinary tract infection. Well, with a classification, urinary tract infection could be classified anatomically or symptomatically. Now, anatomically, we have the lower urinary tract infection. Now, this includes urethritis, that's inflammation of the urethra from urethral infection, cystitis, that's inflammation of the bladder due to bladder infection, and upper urinary tract infection, that's pyelonephritis, that's inflammation of the kidney due to bacterial infection. Symptomatically, well, we could have asymptomatic bacteriuria. So this is where there's greater than 100,000 organisms per milliliter on a clean catch urinalysis obtained from an asymptomatic patient. Now with this, The individual does not usually present with the symptoms of urinary tract infection. That could include dysuria, nocturia, and so on, as we will see later. However, when the urinalysis is done, there is actually greater than 100,000 organisms per milliliter on a clean catch urinalysis or the midstream specimen of urine. Then we also have the symptomatic or true bacteriuria. That can be seen in cystitis. That's, as we already stated, that's the inflammation of the bladder. Pyelonephritis, that's inflammation of the kidneys. Now with this, what actually happens is that the individual presents with the signs and symptoms, including dysuria, nocturia, frequency, and so on, as we'll see later. And usually with cystitis and pyelonephritis, there is also evidence of bacteriological infection. That is where with the clean catch urinalysis, there could be greater than 100,000 microorganisms or uropathogens per milliliter of urine. However, sometimes there could be no evidence of bacteriological infection. However, that's sometimes usually associated with chlamydia infection. However, the individual may present with urinary tract infection symptoms, such as dysuria, nocturia, frequency, and what have you, as we'll see later. And this is usually seen in acute urethral syndrome. So there is no evidence of bacteriological infection. However, the individual presents with urinary tract infection symptoms, dysuria, nocturia, frequency, hematuria, and what have you. And this is usually seen in chlamydia trachomatis infection. And it's common with the acute urethral syndrome. So as we already saw, with the talking more of the asymptomatic or covert bacteriuria, as I said earlier, the individual does not usually present with the symptoms of urinary tract infection. However, in the urinalysis or with the investigations that's done, there could actually be greater than 100,000 microorganisms per milliliter of urine. That's with the midstream specimen of urine or a clean catch urine sample. So with this, the incidence in pregnancy is about 5 to 6%. However, it may increase to up to 10% in high-risk population. The prevalence is the same, both in pregnant women and non-pregnant women. It is 2 times more common with sickle cell patients. As I stated earlier, with sickle cell disease, the organs are usually affected, including the kidney, and the white blood cell counts are usually high, which impedes its fighting against infections adequately. That influences the susceptibility of especially pregnant women to urinary tract infection. And straight times in diabetics, as I already stated earlier, with the increased sugar levels, there's also increased levels of sugar levels in the blood. There's also increased sugar levels in the urine, and thus providing a perfect breeding ground for bacteria to thrive. If untreated, about 30 with the asymptomatic or covert bacteriuria, if untreated, about 30 to 50% of cases will develop acute pyelonephritis. There could also be relapse or reinfection of the treatment. And hence, we do find, especially with pregnant women, it'll come, and then we treat the urinary tract infection, and they come again for us to treat, and we pick up urinary tract infection again, and we have to treat it again. So there could be reinfection after treatment. So with a symptomatic or true bacteriuria. Now, usually with a symptomatic or true bacteriuria, here the individual presents with the signs and symptoms of urinary tract infection, dysuria, nocturia, frequency, and others, as we'll see later on. And with 2 consecutive midstream voided urine specimen or a single suprapubic urine aspirate or urethral catheterized specimen, there could be significant bacteriuria. Now, this is usually correlated with the signs and symptoms of urinary tract infection to say it is symptomatic or true bacteria. So usually it starts starting from the lower urinary tract infection. Starting from the lower urinary tract, there could be urethritis, that's inflammation of the urethra. That is usually mainly caused by chlamydia trachomatis and often coexists with mucopurulent cervicitis. We come to the bladder, where there could be inflammation of the bladder causing acute cystitis. And the incidence is about 1% during pregnancies. Then we come to the kidneys, where there could be inflammation of it, usually from bacterial infection causing acute pyelonephritis. Now, this usually occurs with 1 to 2% of pregnant women. Now, as I stated earlier, with the enlarging uterus during pregnancy, it compresses on the ureters and the bladder, causing obstructive uropathy. Now, this influences or causes stasis of the urine, providing a pabulum for thriving bacteria or for the uropathogens to thrive or for their proliferation and growth, thus causing pyelonephritis. If untreated, asymptomatic bacteriuria could also lead to pyelonephritis. Now, with a mode of infection or spread, well, it could be spread hematologically or from lymphatic communication between bowel and urinary tract. There could also be ascending infection. So as I said, especially with sexual activity. Now, the uropathogens usually located with around the area near the anus. Now, with the sex, it could be transferred to the genital tract and subsequently to the urinary tract. Starts from the urethra, causing urethritis, and due to their short urethra, it could actually ascend to the bladder, causing cystitis, and subsequently ascend to the kidneys, causing pyelonephritis. With iatrogenic, as we already stated, with a tight sling for treatment of stress incontinence, it could actually lead to urinary stasis, and thus providing a conducive environment for the microorganisms to proliferate and grow, thus making them susceptible to urinary tract infections. Oh, good. So we now come to the clinical presentations. We have the symptoms of and the signs. Now, the individual may present with frequency, urgency, dysuria, suprapubic pain. Usually, especially, they usually come a lot with suprapubic pain. And then we ask for the others and then they tell us about it. Or lower abdominal pain. Then they could also present with hematuria fever, usually of a temperature greater than 38.5 degrees Celsius. It could be greater than 37.5, but usually it's greater than 38.5 degrees Celsius. Others include chills, rigors, nausea, vomiting. Now with pyelonephritis, individuals usually present with flank pain. So they will come and tell you the right flank or the left flank is pain, or even with bilateral flank pain, or they present with bilateral flank pain. Now with this, when they present, we usually have a high suspicion for pyelonephritis. And hence we ask them for the other urinary symptoms, and they do confirm that they do have frequency, urgency, dysuria, and what have you. They could also have headaches. Now with the signs, there could be pallor. Now they usually are warm to touch. There could be tachycardia, lower abdominal tenderness, that's on palpation. And then especially with those who present with flank pain, some even come without actually, they have flank pain, but they present with the other symptoms such as frequency, urgency. But on assessment or with examination, we could pick up a renal angle tenderness. Now, it could be isolated in one side, or it could actually be bilateral. And this gives us a high suspicion for pyelonephritis. Right pyelo, left pyelo, bilateral pyelonephritis. . So with some investigations, well, we can actually do the urine dipstick or the urine for routine examination or cultural sensitivity. Now with these, we actually have to educate them on how to take the sample. That is what we usually want, the midstream specimen of urine, the midstream specimen of urine. So with that, we actually educate the patients on how to take it, where we have to tell them that, first of all, they have to void a little bit. They have to void a little bit. And then after voiding it a little bit in the toilet or in the bathroom, then they start to take the sample. So they try as much as possible to avoid their hands touching the inside of the container. And then they take the sample after voiding just a little bit in the bathroom or in the toilet. And then when they take adequate samples, then they void the rest in the bathroom or the toilet. So usually we have to educate them before, because as soon as they enter, some of them, they just start taking it from the beginning. But we have to educate them on how to take to obtain the midstream specimen of urine. So we tell them they void a little bit, then they take, after voiding a little bit in the bathroom or the toilet, they start taking the sample, trying as much as possible to avoid contact of their hands on the sample, the insides of the sample bottle. And then they take, and then they collect adequately, and then they void the rest in the toilet or the bathroom. Now, it should be noted that with the clean catch specimen, it is a way of the collecting urine that does not contain a lot of bacteria from the skin. The reason why we do collect the midstream and not the earlier flow, is to prevent as much as possible contamination from bacteria on the skin. To prevent as much as possible contamination from bacteria on the skin. So we allow them to void a little bit, then take the sample, and then avoid touching the insides. And we allow adequate samples. After adequate samples taken, we allow them to void the rest in the toilet or bathroom. So with the full blood counts, white blood cell counts are usually quite high, and that could point us to an infection. The HBs sometimes may also be low. We can also do the ESR. Then we also do the blood urea electrolyte and creatinine. Now with that, with the blood electrolyte and creatinine, you want to see the kidney functions. We can also do a pelvic ultrasound, usually especially with people who come with flank pains, whether it's right, left, or bilateral. Sometimes we also do the abdominal pelvic ultrasound to see what's going on in the abdominal pelvic region. So we come to the treatment. With the treatment, we classify them under pharmacological and non-pharmacological treatment. With the pharmacological, we encourage, with the non-pharmacological, we encourage that they drink plenty of fluids. That is, we try as much as possible to promote good urine output, to flush out the uropathogens. Now with this prevents the stasis or collection of urine for long periods in the urinary tract. So we encourage that they drink a lot of fluids or water in order to promote good urine output, to flush out the microorganisms or the uropathogens or the bacteria out, in order to prevent stasis and accumulation for long periods in the urinary tract. As we already stated earlier, this actually creates perfect breeding grounds for the uropathogens. Well, we also encourage good personal hygiene, especially perineal hygiene. As I stated earlier, usually the uropathogens that cause urinary tract infections are usually found in the area near the anus. So what happens is that it can be transferred due to, if good personal hygiene or perineal hygiene could prevent the transfer of uropathogens from the area near the anus to the genital tract and subsequently to the urinary tract. And hence we encourage that they avoid frequent douching And they avoid the use of detergents. They keep the place dry and wear loose underpants made of cotton. And we also tell them that they should clean after defecation. They should clean from front to back and not back to front. Because as I stated earlier, cleaning from back to front could actually introduce the uropathogens or the bacteria into the genital tract and subsequently to the urinary tract, thus leading to infection of the lower urinary tract, urethritis, ascending to be due to their short urethra to the bladder, causing cystitis and potentially to the kidneys. So we encourage that when they clean from front to back and not back to front. That's after defecation. We also encourage patients to urinate often. Whenever they feel like it, then they go. They should withdraw as much as we saw in the risk factors. Infrequent voiding could actually lead to stasis of the urine and also providing a pabulum for the proliferation and growth of the uropathogen. So we are encouraging them to void often. That's whenever they feel like it. Now, it is generally stated or is known that the eating a balanced diet actually, or improving nutritional status, actually improves the capacity of the immune system, thus fighting against infection, including urinary tract infection. So we encourage that they improve their nutritional status by eating a balanced diet usually, especially diets, high protein diet and vitamins. Now it is also known that the modulation of iron levels in the bladder may provide a therapeutic avenue for controlling urinary tract infection. The modulation of iron levels in the bladder may provide a therapeutic avenue for controlling urinary tract infection. And hence, we encourage that they eat iron-containing foods such as liver, meat, eggs, spinach, leafy vegetables, peas, and beans. As we already stated, fruits and vegetables boost our immune system. So, yeah, once the immune system is boosted, it aids in the prevention or fighting against infections that includes urinary tract infection. That includes urinary tract infection. So that's with the non-pharmacological treatments, encouraging drinking of fluids to promote good urine output, good personal and perineal hygiene, encouraging the urination often, avoiding often to prevent stasis and accumulation over long periods. That creates a perfect breeding ground for the bacteria and improving their nutritional status. So with the pharmacological management, well, we could actually see it through the different types where we have asymptomatic urinary tract infection, urethritis, cystitis, and pyelonephritis. Now, as we already stated with the midstream specimen of urine, one of the things that we should do is the culture and sensitivity. Now, with asymptomatic urinary tract infection, the choice of drug is usually based on the sensitivity of the isolated organisms. But we could give ampicillin and cephalosporin, usually the second generation cephalosporins or the third generation cephalosporins. Second generation, that's, for example, cefuroxime, or the third generation, if you're treating on OPD basis, such as cefixime, could also be used. However, with ampicillin, it should be noted that its use during pregnancy is if only clearly needed. Its use during pregnancy is if only clearly needed, and the benefits outweigh the risk to the fetus. And if the benefits outweigh the risks to the fetus. So generally, usually in our setting, we usually give the cephalosporins. So we could give the second generation cephalosporins, such as cefuroxime. That's on, if you are doing it on OPD basis, or cefixime, the third generation cephalosporin. Now, nitrofurantoin could also be given. However, it should be noted that with nitrofurantoin, it is best avoided during the third trimester of pregnancy. So usually with nitrofurantoin, we can give it during the first trimester and second trimester. However, with the third trimester, it is best avoided. And the reason is it could cause problems with the baby's red blood cells. So we try as much as possible for the nitrofurantoin to avoid it during the third trimester, as it can affect the baby's red blood cells. So we can give it safely during the first trimester or the second trimester, or the third trimester. We try to avoid it. Now we can repeat the midstream specimen of urine culture 1 week after treatment. This is to make sure that the infection is cleared. As we already stated, there's usually a chance of reinfection. So we find that pregnant women, they usually come over and over again with recurrent urinary tract infections. So repeat the midstream specimen of urine 1 week after treatment in order to make sure that the infection is cleared. With urethritis, erythromycin is effective. With cystitis, well, we can treat it on OPD basis too, where we can give oral antibiotics. Now, this antibiotic, that's why the culture and sensitivity is usually important, where we can, but sometimes it takes a long, in some places, it takes about 3 days to come. Some places, it takes about 5 days to come. Now, so we generally start with the cephalosporins. So second generation, such as cefuroxime, or third generation, such as cefix. That's if you are treating on OPD basis. Then, however, we could, when the culture and sensitivity come, we could actually switch them to the medications that they are sensitive. So usually with the cephalosporins, we can give it for about 7 to 10 days. 7 to 10 days, that's the oral antibiotics. And as I stated earlier, usually when they come with suprapubic pain or dysuria. Sometimes when they have frequency, or they just think it's normal, so they usually don't. But when they come with lower abdominal pain or suprapubic pain, and we can also give them analgesics such as paracetamol can also really be given. With pyelonephritis, actually, we counsel and admit the patient. Pyelonephritis, we counsel and admit the patients. As we already stated, we want a good urine output, so we give the individuals IV fluids. We can give Ringer's lactate for hydration, where we actually try as much as possible to flush out the bacteria. We encourage urine we give them the IV fluids to encourage adequate urine output. We start them with IV antibiotics, such as usually we start with the cephalosporins. We can even go higher to the third generation cephalosporins, so ceftriaxone. And then while we are awaiting the results of the urine culture and sensitivity, Now, as I stated earlier, they come with flank pains with pyelonephritis. They come with flank pain. And usually when you elicit the renal ankle tenderness, you realize that it's actually present, whether it's right, left, or bilateral. So we also put them on, we can put them on paracetamol, since it's both an analgesic and an antipyretic. So we can give them the IV paracetamol with the antibiotics given. And we also monitor with this, we also monitor the fetal conditions, as it could lead to urinary tract infection, could lead to preterm labor, actually. Generally, not only just pyelonephritis, but urinary tract infections usually can lead to preterm labor. And with the results for the culture and sensitivity comes out, then we can switch the antibiotics. But we can repeat after treatment, that's 1 week after treatment or 7 days after treatment, we repeat the urine culture to know whether the infection is cleared or not. And now we come to the complications. Well, with the complications, we can divide it into fetal complications and maternal complications. Now, with fetal complications, we have the intrauterine growth restriction, which is now usually used. The usually used term now is fetal growth restriction. Then there could also be an intrauterine fetal death, preterm delivery, low birth weight neonates or infants. So with the maternal complications, we have preterm labor, hemolytic anemia. And this is the hemolytic anemia is usually endotoxin induced. Now there could be endotoxin induced hemolysis, and that could lead to hemolytic anemia. That's why in the investigations, as I stated earlier, with a full blood count, sometimes there could be a low HB. With urinary tract infection. And this could be due to the endotoxin-induced hemolysis that could cause hemolytic anemia. There could also be renal failure. And in the investigation, as I stated earlier on, we do the blood urea electrolyte and creatinine to know the renal function. And there could also be septic shock in pyelonephritis. That's usually also endotoxin-induced. There could also be pulmonary injury or edema that is usually endotoxin-induced from the uropathogens. And there could also be hypothalamic instability. Thank you. And these are my references.
Excellent. Thank you so much, Dr. Khaliq, for an excellent job done within about 40 minutes. And I'm sure we've learned a lot. I would let Dr. Howard come in and add in if she wants to, and then we address the questions. So there are some questions in the chat box. We'll take that. And then shortly after, if you want to ask any question, then you can electronically raise up your hand, and then I will unmute you to ask our panelists, and I'm sure your question will be addressed. So Dr. Howard, please, over to you.
Okay, thank you so much, Dr. Khaliq, for such a detailed and well-explained presentation. I think that he's hit on all the salient points that I think has to be driven home so far as urinary tract infection is concerned. It's a common thing amongst pregnant women. It is something that the pregnant woman will have without any symptoms. So we should really be cautious of asymptomatic bacteriuria. And it will still give her complications. If the pregnant woman doesn't have symptoms, it doesn't mean that she cannot have a urinary tract infection. It's for that reason that the booking visits, we do all these labs, including a urinary, because you will pick up these infections from there. And when they have the symptoms, let's not be satisfied with empiric treatment alone. Doing a culture and sensitivity will help you identify the bacteria pattern in your facility or your neighborhood or your community, and the antibiotic sensitivity patterns, and whether or not your treatment is effective or not. So I think that he said everything salient that I think he should have said, and we'll keep the door open now. Maybe the questions will stimulate some more information that we have left out. Thank you.
Thank you. Excellent. So we go straight on to get the questions. I think we've had a couple of them in the chat box. We just address those, and then if you have any question that you want to ask, then you electronically raise up your hand. I would unmute you, and then you can go ahead and then ask. Just a quick one by way of announcement before we start the questions in the chat box. So if you look in the chat box, I've just put up our social media handles there. If you want to know the topics that we do on weekly basis, usually we'll put them on our Facebook and LinkedIn page. The links are posted both in the chat box. So you click on any of those links, and then you can like our pages either on Facebook or on LinkedIn. As well, you realize this is being recorded. Usually we record and then we upload this, including the PowerPoint slides, on our YouTube channel. So if you do subscribe to that as well, then you can have the videos, especially if you joined in late or you want to look at what we did previously, you can have all of that. Right from about 2 years ago to now, we have a couple of those presentations up. So thank you so much for joining. So straight to the questions that are in the chat box there. First one, I think, came from Esther, and she asks, when urine test is done and it indicates red blood cells above 30, blood positive, can this be a UTI? So Dr. Howard, Dr. Khaliq, any response to that?
Okay, so if you have a test done and they see significant red blood cells in it, the first question you will have to ask yourself is whether or not the sample was adequately taken. Dr. Khaliq hit the nail very hard when he got to that point that we should educate our clients well when we ask them to go and take the sample, because sometimes they don't know exactly what we want. They will apply the container right at the vulva and wee into it. And then whatever is around that area will also get into the container. And so if this blood, she's bleeding per vaginum, she may have it inside. Sometimes not even only blood, even protein. So she has vaginal discharge and she gets some into the urine sample. It will come as protein positive. So you have to be careful or you have to be very sure how the sample was taken. However, if you have an adequately taken sample that has blood in it, then it can fall in a cystitis. Cystitis, remember, is inflammation. And once there is inflammation, you can have oozing of these blood cells into the urine. It can be something more sinister coming from higher up. You can have a pyelonephritis if it's still within the infection area. It can even suggest that there are stones in the bladder, in the urethra, inside the kidney itself. So we have to take blood cells in the urine sample very seriously, and it can even suggest malignancy. So it is important once you see it, if your primary thought was that it's a bladder infection, yes, go ahead, take your samples for culture and sensitivity, start your empirical treatment. You expect it to clear, especially if you were on the right track after your culture comes in. But then if it's persistent, then you should be thinking of all the other things I mentioned. Thank you.
Thank you so much, Dr. Awa. The next one is from Sani, and he says, in pregnant women, usually there are physiological changes within the genitourinary system. So must we always rely on laboratory investigations before treatment? The investigation, so that's part of his question. The second one is the investigations. Can we add the high vaginal swab for RE and for culture and sensitivity? So the first part was whether we should wait or rely on laboratory investigations. I think that has been addressed, but if you want to highlight again on it, and then whether the investigation we can do a high vaginal swab. Thank you.
I think Dr. Khaliq, you can take a go.
So thank you. As I said earlier, usually we can do the midstream specimen for urine, and also that's for routine examination and also culture and sensitivity. Now the culture and sensitivity will tell us which organisms are isolated and also the medications that they are sensitive in. As my boss, Dr. Howard, just said, yeah, this is very, very important because we don't know whether we are adequate. Although we start with the empirical treatment, we can start with the as I stated earlier, the cephalosporins, either second generation or third generation cephalosporins. Second generation cephaloxam or third generation cephalosporins, maybe if it's an inpatient ceftriaxone or if an outpatient cefixime. However, the culture and sensitivity will actually tell us which organisms are isolated and which medications that they are sensitive to. So that will make us effectively treat the urinary tract infection. So as you stated earlier in the previous question, it is very important that we do the investigations, and the culture and sensitivity, as you saw in the slide with the pharmacological treatment, will tell us what exact medications to give for the urinary tract infection. I don't know whether Dr. Howard wants to add something to it.
Okay, I think you just said it. It is important we get to know what's going on. And although we are aware of the physiological changes that pregnant women go through, that is why I said that at the onset of pregnancy or the first contact with the pregnant woman, you assume that she may have asymptomatic bacteriuria. So as part of your booking laboratory investigations, there is urinary, and that will help you pick up some of these things. Now, when it comes to adding HVS to it, yes, it's good to do HVS. It also covers something else, not necessarily the UTI, because you are looking at what is going on within the vagina. It is not to suggest that once the HVS is positive, it means that the woman has UTI. They are two different anatomic areas, and those two tests mean different things.
Great. Thank you so much, Dr. Khaliq and Dr. Howard. The next one is from Maxwell. He says, sometimes there's a considerable amount of protein leaking through the urine without the signs and symptoms of a UTI. Can UTI be diagnosed? Leaking proteinuria without signs and symptoms of a UTI. Can we still diagnose a UTI? Dr. Khaliq?
Yeah. So with proteins, actually, yes, proteins could actually also be present in urinary tract infection, but usually proteins could also be present with other things such as dehydration. Maybe there could also be contamination with vaginal discharge or something. So that's why we emphasize on the midstream specimen for urine, that we actually use the clean catch urine sample for routine examination and culture and sensitive. So obviously, of course, proteins could also be present in urinary tract. However, it could also be present in other things. For example, even with preeclampsia, there could actually be proteinuria and other sort of dehydration, contamination with vaginal discharge and what have you. So that's why we educate the individual on how to take the midstream specimen of urine, and we do the urine routine examination and culture and sensitivity in order to know the organisms isolated and also the medications that they are sensitive to.
Great. The next question is from Azong Abdul. He mentions, or he's asking, please, how safe is levofloxacin in pyelonephritis in the second trimester? Dr. Khaliq?
Hello, I didn't get that. I didn't get that.
He's asking about the levofloxacin.
So generally, levofloxacin is generally said we should be avoided during pregnancy. However, they also said that if the risks,
there are so many other medications you can safely give in pregnancy. So we avoid quinolones in pregnancy. We don't give any of them in pregnancy. So it's just safe to avoid them.
Great. So let's see if there's any more. So Levo that answered. Then Nasi says, in the treatment of UTI, please, is it advisable to treat the sexual partner as well, since we have identified sexual activity as a risk factor?
What I said about the sexual activity is that any form of sexual activity could actually lead to the transfer of, but the uropathogens are usually found in the areas near the anus, and any form of sexual activity could actually lead to the transfer of urine of the uropathogens from the area near the anus to the genital tract and subsequently to the urinary tract. So it's not really the partner actually giving the sexual partner actually giving the lady the urinary tract infection, but it's just the sexual activity that leads to the transfer of organisms from the area near the anus to the genital tract and subsequently to the urinary tract. I don't know if it's clear.
Yeah.
Yeah.
Yeah, so I think that's it from, let me quickly see if there's any more. Yeah, I think so. One just came in. Please, what?
Hello, Dominic.
Yes.
Can I
But,
add something to it?
yes,
Yeah.
sure.
So,
Easy.
yeah. So when it comes to sexual activity and UTI, I mean, aside what Dr. Khaliq has just said, movement of the penis to and fro from outside to inside carries things from the neighboring areas to the wrong places. And also the act also bruises the bladder. Remember, there's a close relationship between the vagina and the bladder, depending on how that's why we have a term called honeymoon cystitis. So the more sexual activity and rigorous the sexual activity is, there can be bruising. And once there's inflammation, that means that you have broken barriers, epithelial barriers, and then these bacteria can easily get in and you have a UTI. So in general, looking at the presentation he gave out, he told us that almost 70% of the bacteria that cause UTI is E. coli and Klebsiella. They are not sexually transmitted. However, if in your assessment of the patient, you think that she has urethritis, for example, is gonococcal urethritis, then you would have to treat her partner because this one is sexually transmitted. So majority of urinary tract infections, no, but depending on how the presentation is, and when you do a physical examination, we are thought to do a proper pelvic examination. The last bit of your pelvic examination, you milk the urethra, and then you see that there is a discharge, creamy discharge coming from there. And that is where her complaint is about burning sensation and all that. You milk the urethra and you see this milky discharge from the urethra. Your guess will be that she has gonococcal urethritis. You would have to treat her sexual partner. So it's not an absolute no, but it's not also an absolute yes. Thank you.
Right, great. So the next one is if a patient has few bacteria in the urine, bacteria, asymptomatic bacteria, does she require treatment? I think he did address it, if you want to highlight it again. Yeah.
Yeah, that's what the other pharmacological treatment I mentioned about asymptomatic urinary tract infection. Why I mentioned that we can actually wait for you can actually do the culture and sensitivity. And as my boss, Dr. Howard, just mentioned, that's even at the booking, even though she doesn't present with signs and symptoms, we have to do the urine routine examination, and that could pick up the evidence of bacteriological infection, however, without the symptoms, and that's where we treat. So we can treat them with the cephalosporin, second generation cefuroxime, or third generation with cefixime. However, we also rely on the results of the culture and sensitivity to either switch the medications in order that the individual gets apt treatment for the urinary asymptomatic bacteriuria.
Great. Prospera is also asking that, please, what does it mean when there is ascorbic acid in your urine? Any answer, any response to that?
Could it be that the person is taking vitamin C?
Vitamin C, yeah. That's
so, not typical,
C, yeah.
but with stretching poisoning, and
okay,
a couple of times you can have some acidity in the urine, and if it's not properly with the right kits used, they may report it as ascorbic acid. And so that's for those, and these guys who sniff glue, they tend to have that. So in the toxicological studies they do. But I wonder how many pregnant women will probably be doing that. But it's one of the things, like in the urine examination, that we usually will see when they're doing like toxicological studies or drug.
Okay.
Okay, then Stephen is asking about UTI. Can UTI lead to primary sepsis in neonates at the time of giving birth? I think you highlighted on.
So it's a big yes. Let me just come in on this. I'm happy the question has come. So one of the notorious bacteria that we are worried about, especially antenatal period, is group B streptococcus. And this can lead to a lot of sepsis amongst newborn babies with sequelae. They can have cerebral palsy and other, blindness, deafness, and all the difficult things that you think about. So yes, UTI can end up with bad outcomes for the newborn, even much later. So the woman will have this bacteria during the pregnancy. It's not properly cleared. The baby is delivered and gets contaminated with it, and the baby gets into trouble. Elsewhere, in the high-income countries, they do what we call universal screening. So between 36 and 37 weeks of pregnancy, all pregnant women get a vaginal and rectal swab for the group B streptococcus. And then if they are positive during labor, they are given appropriate intrapartum antibiotic prophylaxis so that they do not pass it on to their baby. So I'm happy the person asked this question, and it's a big yes.
Great. Stephen is a huge advocate for babies in the NICU and elsewhere, so I'm not surprised. And then he's asking about the possible effects of UTI on the fetus. Dr. Khaliq did highlight that, but if you want to highlight it again, that would be good. Dr. Khaliq.
Yeah, so as I said earlier on, there could be intrauterine growth restriction or fetal growth restriction, intrauterine fetal death, preterm delivery, this usually due to preterm labor, then low birth weight neonates or infants.
Great, excellent. So the next one is from Emmanuel. I want him to hit more on the lymphatic and hematological transfer. Dr. Khaliq, do you get that? Can you guys hear me?
Okay, I hear you, but I really don't understand what the
Yeah,
person
exactly.
means.
Same with me. So Emmanuel Yeboah AJ, if you could kindly electronically raise up your hand, I will unmute you so that then you can clarify this for us. Thank you. Then the last question is from Nisi. If a client has been diagnosed with UTI and treated conservatively for 2 times or more, do you continue to treat each time client presents with the symptoms of UTI?
So this, with regard, you can admit the patient and then treat with IV medications after maybe you've treated twice on OPD basis, and the third one you can actually admit and treat on an inpatient basis. That's with the IVs.
Okay.
And in addition, you should ask yourself why. Why is this UTI not going? Is there something else? Because normal UTI should go. So sometimes if the woman has something else, there's a stone in the bladder, she has a diverticulum, she has a kidney problem, there is something else. So it is not just okay to be treating UTI over and over. You have to escalate. If you remember, he mentioned so many risk factors when he was talking about it. One of them is diabetes. Sometimes that might be the only way you find out that a woman has gestational diabetes, repeated infections. So it's not okay to just be treating anytime she comes with symptoms. I remember we had a colleague spouse who kept having UTI. When we realized she had problems high up in her kidney, we needed to stent her kidney during the pregnancy to get her to get better. So if you notice something like that, you need to move the patient upwards. Thank you.
Great. Thank you so much. I think that was the last question in the chat box. And if anyone has any question, you could kindly electronically raise up your hand, and then we allow for you to talk, and then we can bring the meeting to a close. This has been excellent. So anyone with any question, just electronically raise up your hand. Any comment, any suggestion? Don't feel shy, please. Ask, suggest, and help us make these presentations better for everyone. So feel free, just electronically raise up your hand. I'll ask you to unmute, and then you can go ahead. Okay, I guess probably Dr. Khaliq and Dr. Attaruwa have done a legendary job. So really nothing to ask, and no follow-ups. And so I would, on behalf of Ghana Medical Help and everyone with the maternity service agenda, thank all our participants for joining us today. We've been able to do it in 1 hour and 6 minutes. Very important topic, and I'm sure a lot of us have learned. I've definitely learned a lot, and I'm sure it will help guide our practice as well. Just to announce that we are planning to have those that we've trained who are ambassadors for the maternity service agenda, most of them midwives and medical officers and residents, to have follow-up trainings at our district hospitals in the Upper East and the Upper West, where we do work. So we're hoping to do that next month. And so those who have joined us for this meeting, who are part of that training cohort, will be reaching out to you shortly. Also, the weeks following, we'll have another presentation, and kindly like our pages on Facebook or LinkedIn, or you subscribe to our YouTube channel for the videos, and then you can have the updates as and when they are available. I want to thank in a special way Dr. Khaliq for leading this presentation, and Dr. Attaruwa for the mentorship and guidance throughout this, and especially for this presentation. We are grateful. Any closing remarks, Dr. Khaliq and Dr. Attaruwa, before we say we close off for the Friday? Dr. Khaliq, you good?
Yeah.
Fantastic.
Yeah, I'm good.
All right. Dr.
Yeah,
Attaruwa?
I think I'm also good. Let's take home the message that UTI is very common. And when we see it, we should know that it can have effects even on the unborn baby. So let's act on it. Thank you.
Thank you. Fantastic. This has been great. I got a lot of American slangs from Dr. Khaliq today, and it's been excellent. It's been
Hey,
great.
Dominic,
Thank you. All the best, guys. Thank
Hey,
God
all
it's
right.
Friday. God
Everybody,
bless
enjoy your weekend.
Bye-bye.
Bye.